What if you woke up every morning in pain, and no one could tell you why? Not because the pain wasn't real, not because the tests were inconclusive by accident, but because the medical community, despite decades of research, still doesn't fully understand what is happening inside the human body to cause it. No broken bones, no visible inflammation, no tumor on a scan, no abnormal blood work, and yet, pain. Fatigue so profound it feels like the body is running on empty. A fog over the mind that makes even the simplest thought feel like wading through water. This is not a condition invented to explain the unexplainable. It has a name, a diagnostic framework, and millions of people who live with it every single day. Its name is fibromyalgia, and it remains one of medicine's most enduring, most debated, and most misunderstood mysteries. Fibromyalgia is a chronic condition characterized by widespread musculoskeletal pain, persistent fatigue, sleep disturbances, and cognitive difficulties. According to the American College of Rheumatology, it affects an estimated 10 to 12 million people in the United States alone, and somewhere between 2 and 4% of the global population. It is not a rare disease. It is, in fact, one of the most common chronic pain conditions in the world. It tends to affect women more frequently than men, though researchers are increasingly recognizing that this gap may be partly explained by historical underdiagnosis in male patients. It can develop at any age, though it most commonly emerges between the ages of 30 and 50. It is often seen alongside other conditions, rheumatoid arthritis, lupus, and ankylosing spondylitis among them, which has historically complicated efforts to study it in isolation. The hallmark of fibromyalgia is not a single symptom. It is a constellation of them. Widespread pain that affects multiple regions of the body simultaneously. Fatigue that persists regardless of sleep. A phenomenon physicians often refer to as fibro fog, a cognitive impairment involving difficulty concentrating, slowed processing, and memory gaps. Many patients also report headaches, irritable bowel syndrome, and an unusual sensitivity to touch, temperature, and even sound. On paper, the condition sounds almost impossible to define precisely. And that, as we will explore, is part of what makes it so medically fascinating and so extraordinarily difficult to diagnose. At the heart of the fibromyalgia mystery is a deceptively simple problem. You cannot see it. Run a standard blood panel on a fibromyalgia patient. It will likely come back normal. Order an X-ray, an MRI of the joints, a bone scan. In most cases, nothing obvious appears. There are no elevated inflammatory markers, no detectable tissue damage, no structural abnormality that a radiologist can point to and say, "There it is. That is the source of the pain." This absence of visible pathology has been both fibromyalgia's defining characteristic and its greatest liability. For much of the 20th century, that very invisibility led significant portions of the medical establishment to question whether the condition was real at all. Patients were dismissed. Symptoms were attributed to psychological distress. The word psychosomatic was used not as a clinical descriptor, but as a verdict, a way of closing the conversation. Decades passed during which fibromyalgia existed in a diagnostic gray zone, acknowledged in some clinical circles, dismissed in others, and deeply misunderstood in virtually all of them. What made the mystery harder to solve was the sheer variability of the condition. No two fibromyalgia presentations are identical. Some patients experience pain primarily in the neck and shoulders. Others describe it across the entire body. Some are bedridden during flare periods. Others maintain relatively functional daily lives. The symptom burden fluctuates, sometimes in response to stress, sometimes to weather, sometimes to sleep quality, sometimes to no discernible trigger whatsoever. How do you study something that behaves differently in every patient? How do you develop a diagnostic test for a condition with no clear biomarker? And perhaps, most critically, how do you treat pain when you don't fully understand what is generating it? These are not rhetorical questions. They are the actual research problems that have occupied pain specialists, rheumatologists, and neuroscientists for the better part of 50 years. In the past 2 decades, the science of fibromyalgia has undergone a quiet revolution. The most significant conceptual shift has been the move away from viewing fibromyalgia as a disease of the muscles or joints, which is where the name misleadingly points, derived from the Latin fibro for fibrous tissue and the Greek myo for muscle, and toward understanding it as a disorder of the central nervous system itself. The leading contemporary framework is called central sensitization. Here is the core idea. In a healthy nervous system, pain signals travel from the site of tissue damage, say a sprained ankle, up through the peripheral nerves, into the spinal cord, and ultimately to the brain, where they are processed and interpreted as pain. That is the normal pain pathway. Once the tissue heals, the signals diminish, and the pain resolves. In fibromyalgia, researchers believe this system becomes dysregulated. The central nervous system, the brain and spinal cord, appears to amplify incoming signals abnormally, processing ordinary sensory input as pain. The gain, metaphorically speaking, is turned up too high. Normal touch becomes painful. Mild pressure becomes severe. The nervous system is not responding to damage. It is generating pain on its own, independent of tissue injury. This is why fibromyalgia is now often categorized alongside a group of conditions called nociplastic pain disorders, a term introduced by the International Association for the Study of Pain to describe pain arising from altered nociception rather than actual tissue damage or nerve injury. Neuroimaging studies have offered some of the most compelling supporting evidence. Functional MRI research has shown that fibromyalgia patients demonstrate significantly greater activation in brain pain processing regions in response to stimuli that healthy individuals would not find painful. The anterior insula, the anterior cingulate cortex, and the somatosensory cortex all show heightened activity. And critically, this heightened activity correlates with the subjective pain reports of the patients themselves. Researchers have also identified dysregulation in the descending pain inhibition pathways, the systems the brain normally uses to dampen pain signals coming up from the body. In fibromyalgia patients, these inhibitory pathways appear to function less effectively, meaning the brain has a diminished capacity to quiet incoming pain signals. Further investigation has revealed abnormalities in key neurotransmitter systems. Substance P, a neuropeptide involved in pain signaling, has been found at elevated levels in the cerebrospinal fluid of fibromyalgia patients, sometimes 3 times higher than in healthy controls. Serotonin and norepinephrine, both involved in mood regulation and descending pain modulation, also appear to be dysregulated. These findings help explain why medications that target these neurotransmitters, such as the serotonin-norepinephrine reuptake inhibitors duloxetine and milnacipran, both FDA-approved for fibromyalgia, have demonstrated clinical efficacy. Genetics, too, is emerging as a meaningful factor. Family studies suggest a heritable component, with first-degree relatives of fibromyalgia patients showing elevated rates of the condition. Researchers have begun identifying candidate genes related to serotonin transport, dopamine processing, and catecholamine metabolism, though the field is still in early stages and no single gene has been established as causative. The picture that science is building, slowly and carefully, is one of a nervous system that has lost its calibration. And yet, despite this advancing science, fibromyalgia remains one of the most contested diagnoses in modern medicine. The controversy operates on several levels. The first is diagnostic. Fibromyalgia has no definitive laboratory test. Diagnosis is clinical, meaning it is made based on a patient's reported symptoms and a physician's examination. The criteria have changed multiple times. The original 1990 American College of Rheumatology criteria required tenderness in at least 11 of 18 designated tender points on the body. In 2010, those criteria were revised to focus instead on widespread pain index scores and symptom severity scales, moving away from the tender point examination entirely. Some clinicians use one set of criteria, others use the other. This inconsistency creates real diagnostic variability, meaning the same patient could receive different diagnoses depending on which physician they see and which framework that physician applies. The second level of controversy concerns etiology, the question of what causes the condition in the first place. Central sensitization is the dominant model, but it is not universally accepted, and it does not fully explain the origins of the sensitization itself. Why does central sensitization develop in some people and not others? Is it triggered by physical trauma, infection, psychological stress, or some combination thereof? Current evidence points to all of these as potential precipitating factors, but no single causal pathway has been confirmed. The third controversy is one with deeper clinical and ethical dimensions: the ongoing debate about the relationship between fibromyalgia and mental health. Studies consistently show high rates of anxiety, depression, and post-traumatic stress disorder in fibromyalgia patients. This association is real and statistically robust, but interpreting it remains deeply contested. Does psychological distress cause fibromyalgia, exacerbate it, or simply co-occur with it because chronic pain is itself psychologically devastating? Historically, that ambiguity was often resolved, incorrectly, by dismissing the physical component entirely. Today, most researchers favor a biopsychosocial model, which holds that biological, psychological, and social factors interact and mutually reinforce one another. But translating that model into clinical practice, without sliding back into dismissiveness, remains an ongoing challenge. There is also debate within the research community about treatment. The evidence base for fibromyalgia management includes pharmacological approaches, the aforementioned SNRIs, pregabalin, low-dose naltrexone, as well as non-pharmacological interventions like aerobic exercise, cognitive behavioral therapy, and mindfulness-based stress reduction. Multiple clinical trials have demonstrated benefits across these approaches, but effect sizes are often modest and highly variable across individuals. No treatment works for everyone. No treatment eliminates the condition. This frustrates patients, challenges clinicians, and reflects the underlying reality that fibromyalgia at present cannot be cured, only managed. Some researchers have pushed further, questioning whether fibromyalgia is a single condition at all, or whether it represents a final common pathway for multiple different underlying processes that happen to produce overlapping symptoms. If so, the search for a unified treatment may be fundamentally misguided, and the field may need to move toward personalized subtypes of care. These debates are not resolved. They are active, ongoing, and consequential for millions of patients. It would be easy to abstract fibromyalgia into the realm of pure scientific inquiry, a puzzle to be solved in a laboratory, debated at conferences, published in journals. But the scale of its impact makes that abstraction impossible to sustain. Fibromyalgia is a leading cause of work disability. Studies estimate that between a quarter and a third of fibromyalgia patients are unable to maintain full-time employment due to their symptoms. The economic burden is substantial. A 2012 analysis published in the Journal of Managed Care Pharmacy estimated annual costs associated with fibromyalgia in the United States, including direct medical costs, lost productivity, and disability payments, at between $12 and $14 billion. More recent estimates place that figure considerably higher. Healthcare utilization among fibromyalgia patients is disproportionately high, not because patients are seeking unnecessary care, but because diagnostic delays are common and symptom management is complex. The average fibromyalgia patient sees multiple physicians before receiving an accurate diagnosis. That diagnostic journey can last years, sometimes more than a decade. During that time, patients undergo repeated testing, receive multiple incorrect diagnoses, and often encounter skepticism from the healthcare system itself. This matters beyond economics. Delayed diagnosis means delayed treatment. It means years of suffering without a framework for understanding that suffering. It means for many patients being told that what they are experiencing is not real, a message that compounds the physical burden with a profound psychological one. There is also a health equity dimension worth acknowledging. Research suggests that Black and Hispanic patients face even longer diagnostic delays than white patients with equivalent symptom profiles. Gender disparities in pain management more broadly, well documented in the medical literature, compound this effect, given fibromyalgia's higher prevalence in women. The barriers to accurate, timely, respectful diagnosis are not evenly distributed across the population. Fibromyalgia also places significant strain on relationships, family systems, and social participation. The invisible nature of the condition creates a particular kind of social burden. Because sufferers often appear healthy to outside observers, the legitimacy of their experience is frequently questioned, not only by clinicians, but by employers, insurers, and sometimes even family members. Understanding fibromyalgia more fully is not merely an academic exercise. It has direct, concrete implications for the quality of life of a significant portion of the global population. Medicine has come a long way in understanding fibromyalgia. 50 years ago, it barely had a name. 30 years ago, it had a name but no diagnostic consensus. 20 years ago, it had a diagnosis but no approved treatments. Today, it has neuroimaging data, genetic research, FDA-approved medications, and a growing recognition within the medical community that central sensitization represents a real, measurable biological phenomenon. That is genuine progress. But the central mystery remains. What causes the nervous system to lose its calibration in the first place? Why does it happen to some people and not others, even among those who share similar genetic profiles and similar life experiences? What is the precise neurological mechanism by which widespread pain arises without tissue damage? And is there a path, pharmacological, behavioral, neurological, towards something closer to a cure? These are not questions medicine has given up on. They are questions that are actively being pursued in research centers around the world, with increasingly sophisticated tools and increasingly nuanced frameworks. But they have not yet been answered. And in that gap, between what science now understands and what it has not yet explained, fibromyalgia remains what it has always been, a genuine, enduring, and humbling medical enigma. So here is the question we leave you with tonight. If the nervous system can generate pain without injury, can it also, with the right intervention, learn to stop? If this episode raised more questions than it answered, that's by design. Medicine's greatest mysteries don't resolve in 20 minutes. They unfold over decades of research, debate, and discovery. And here on The Medical Enigma, that's exactly what we follow. If you want to stay with us as we investigate the conditions science hasn't fully cracked, subscribe to the channel and hit the notification bell so you don't miss the next episode. We're not interested in easy answers. We're interested in honest ones. We'll see you next time.